Good evening and welcome to Your Health, Your Action. This is the third program in the series where it is indeed all about giving you the information so we can all take effective action. This is a national effort and we're happy to have as partners media across Barbados, including the Starcom Network and of course right here at the CBC, the radio and television services. We have a number of other non-governmental organizations involved in providing this information for you as we tackle head-on this fight against these chronic non-communicable diseases. In the first two programs, we focused on hypertension, and this week we turn our attention to diabetes, specifically focusing on impotence and amputations. Amputations, a word nobody likes to hear about, but certainly these are real situations that persons living with the condition can be impacted by. So, good evening. I'm Cassandra Crawford. Again, it's great to be here with you, and I want to say welcome back and good evening to my co-host, David Ellis.
Thank you and good evening, Cassandra. Rest assured that people don't want to hear about impotence either.
Indeed.
And against that background, we have some specialists with us this evening. To deal with the issues related to amputations, we have a surgeon, a consultant surgeon who's worked with the Queen Elizabeth Hospital for many years, and Dr. Selwyn Ferdinand. And we also have a podiatrist as well as a nurse. Our podiatrist is Tony Pickering, and the nurse is Tracy Bushell. So they will be focusing primarily on your questions relating to amputations and the complications that can cause that. And when it comes to this whole question of impotence, we have Dr. Paul Rouse, who is a urologist. So we want you to take the opportunity to call us and call them in particular. These are your numbers, 228-5562 and 228-5563. We'll be right back. Okay.
Yes, so well, we're going to keep things moving for now. We want to remind you, you can also WhatsApp any questions to that number, 228-5562. So if you have any questions, you can always send them there as well. So you have options in terms of how to do that. So to get the program moving this evening, we told you we're focusing on diabetes. So we're giving you the reality and experience of someone living with diabetes and managing with one of the complications of an amputation. So this feature is all about Giles Bend. David Ellis had an opportunity to chat with him earlier this week. Let's take a look.
Giles Bend is a retired teacher who lost his right leg to complications from diabetes 7 years ago. Coming from a family with a history of the disease, he recalls struggling for quite some time to find the right medication to control his diabetes, which was manifesting itself in frequent urination. According to Mr. Bend, it was a problem that persisted for about 5 years.
But once I started taking insulin, the frequent urination and things like that settled down. So, and the body seemed to be coping with the incidence of diabetes and with the uses of the insulin. So the body sort of, I mean, as far as I can say, settled down. But all during the course of this kind of diagnosis with the diabetes, my body I never really felt sick. So I just continued living life as usual, as though I was not a diabetic. This might sound a bit gross, but one of the types of medication I was placed on used to bring on uncontrolled diarrhea. So I decided I wasn't going to take that because at the time I was still teaching. So imagine being in front of a class. When I say uncontrolled diarrhea, imagine being in front of a class and this urge, let me say, overcomes you. So this urge to go to the bathroom is there, and you rush to go to the bathroom, and God forbid you get to the bathroom and somebody else has the space occupied and you can't get in there. Because it wasn't the kind of thing that you could hold and squeeze back and hold, because these tablets brought on this kind of thing that was a rush. So therefore I decided I wasn't going to take those. So as a matter of from not taking those, the effects of the diabetes got worse. So this brought on loss of sensation in the lower limbs, in terms of numbness in the lower limb.
One day, Mr. Ben stepped on a piece of wood and got stuck with a small nail. Though he went to the doctor to have it attended to, the condition of the leg got from bad to worse.
The foot had deteriorated so badly. But meanwhile, the pain was severe. So I went back to the doctor, and she told me, well, she told me that she changed the dressing. She changed the dressing on the foot. And when she took the dressing off, even though the top of the foot was not infected at that time, when she took the dressing off, the skin at the top of the foot came off on the dressing. And it startled me, so I asked her, it startled her too, because she said, so I asked her, so doc, what's wrong? Something's wrong. Because she put the thing back down fast. And I said, well, I want to see what's happening. So she took it up and she showed me. And then she told me, well, Mr. Ben, you have to go to the hospital with this foot. I said, but that's what I was trying to avoid, because there's cut off your foot up there. So in my hesitation to go and get the kind of treatment that was necessary is probably what caused the demise of the thing to go from bad to worse.
He has some advice for other diabetics.
We have a group of amputees. It is called the Rehabilitating and Enabling Society for Amputees, RISA. The thing about it is that I've spoken to a number of amputees, and I've told them, well, one of the key things is that if you're diagnosed with diabetes, do not take it for granted, because it is one of those diseases. They call it one of the silent killers, but it's one of those things that can do things to cause your body to deteriorate, and you wouldn't realize that these things are happening to you.
Mr. Giles Ben sharing his experience there. He is living with diabetes and managing his lifestyle condition as an amputee. So a number of interesting points coming up there, David, about mistakes he made in trying to address that situation. But we're going to talk a lot about that. We have a number of specialists here this evening. And as you mentioned earlier, the other word, which is one of the other complications of diabetes that nobody wants to hear about, that impacts men directly, would be impotence. So we want to get into that part of the conversation first and foremost.
So we want to hear from Dr. Paul Rouse, a urologist, about the factors that influence this kind of condition coming out of a person suffering from diabetes. What causes this situation of people becoming impotent?
Good evening, Barbados. Thank you for having me on the show tonight. The reasons why diabetes leads to impotence or erectile dysfunction are really quite multifactorial, in that, as our diabetic patient highlighted, is uncontrolled diabetes in the long term leads to really what he was describing is really he developed what we call peripheral vascular disease, where it attacks the blood vessels or the blood supply to his leg, and therefore when he got that, when he stepped on a piece of wood with a nail, his leg wasn't able to heal. So we have a similar pathology happening basically in the penis, or compromising the blood supply to the penis. So really diabetes, long-term uncontrolled diabetes, leads to damage to the blood vessels to the penis. An erection is really a vascular event. So therefore, if you do not have a good blood supply into the penis, therefore then you have problems with erections. And that is how one way in which diabetes leads to that is from the vascular damage, but also the high blood sugars can also cause damage to the nerve to the penis, and hence as a result, therefore the signals or the telling the penis to become erect are also disturbed with long-standing diabetes. So these are some of the ways in which diabetes affects the erectile function in men, not only from the vascular, not only from the neurological, but again, the patient there highlighted one of the other problems with uncontrolled diabetes is that you have a lot of bladder dysfunction associated with that. And therefore, if you run into the bathroom to pass urine a lot, if you can't get a good night's rest, it then impacts you psychologically. And the last thing you want to be doing is considering having sex and having to rush off to the bathroom. So again, it also not only affects you physically, but also psychologically because of those issues of having to avoid very frequently.
How much
trying
fear?
to keep it very simple.
How much fear do you sense there is among men in this country about becoming impotent? And to what extent is that fear perhaps keeping them away from the doctor?
It is a real fear, and understandably so, a genuine fear. But I would love to reassure men that there's lots that we can do to help them. And I know we're focusing on men, but actually women do have a lot of sexual dysfunction as a result of uncontrolled diabetes as well. And I'm sure my gynecology colleagues can touch on that at some point in time. But men do have a great fear of having erectile dysfunction. I think generally in our Western society, there's tremendous pressure on men to perform sexually, and it's kind of frowned upon. If a man cannot perform sexually, then really and truly he's not a man. And this adds further to the psychological impact that having problems with erectile function, it further compounds it. So you go into a vicious cycle of you're worried about performance, you perform poorly, it then makes your psychological, it reduces your confidence, and the whole cycle just repeats itself. So there is a very tremendous psychological component based on our Western values of placing sex and sexual function very high on the agenda.
Andrew?
Yeah, it's another reminder of how important it is for us to include the psychology aspect of that, and we'll do that on the next show. But hearing all that Mr. Bend also mentioned in terms of timeliness, what would you want to say about the importance of getting an early diagnosis so that you can maybe have a better quality of life and not suffer all these complications that we're dealing with this evening?
No, Cassandra definitely hit the nail on the head there in terms of it is all about prevention rather than cure, because I'm afraid that a lot of the things that become rather invasive after the oral medications don't work. So the best thing really is to prevent it in the first place. So managing your diabetes, controlling your diabetes is the best way to prevent erectile dysfunction. Unfortunately, when you do develop erectile dysfunction, there is quite a bit that we can offer. There are drugs to help aid with erections. As I said, it's all a vascular event. So more or less all these drugs basically aim to increase the blood supply to the penis, dilate the vessels. They work in several different ways, from the PDE5 inhibitors, like the common Viagra, Cialis that most people know about, tadalafil. And also I will really touch on this point in time, as well as the overly competent medications, or shall we say herbal products that a lot of people take from, at the pharmacies. A lot of these products are touted to be natural, but actually I would like to caution men to a certain extent to be aware that they do contain sometimes low doses of the common sildenafil and tadalafil, and that is really what actually is giving them helping to improve their erectile function. But just be cautious in that, especially if you have heart disease or other conditions, that these products do contain some low doses of these products, and it's not regulated. That's the problem between a herbal product or natural remedy versus a drug, where a drug has to be a set quantity and a set dose and proven that it's worked. However, saying all of that, these products do work, and so therefore it's good to always have a discussion with your doctor about these. So after the tablets, which most commonly are your phosphodiesterase inhibitors don't work anymore, there are other options that are available. Desperately working with my pharmacy colleagues to give some other options, including intracavernosal therapies, their topical agents as well. And unfortunately, if all thing else fails, we then have to look at things like penile implants. But I want to give men the confidence that there's lots of that we can do to help with their erectile function, and therefore they shouldn't be afraid to have that discussion with their doctors, with their GPs initially, and your friendly pharmacist as well. And then if the medications are not working and we need to look at more invasive treatments like intracavernosal injections or at a last resort penile pumps, these are things that we can have a discussion with your urologist about. Some of my colleagues do offer penile implants, and therefore that I would refer those patients appropriately, and or we can talk about the intracavernosal therapies. I'm trying to get that organized, hopefully within the near future, that we'll have those drugs on island. There have been some issues with supply chains, but hopefully they will be here soon to give them some more options besides the tablet.
You need to explain what this therapy is briefly, in language that people can clearly understand. And out of curiosity, what's the price of getting a penile implant?
Because I don't perform them here, I did wanted to potentially offer that. I do know some of my colleagues do offer the penile implants, so I would therefore recommend that you would probably see one of my colleagues to get a better idea of the price for penile implants. I wouldn't be able to say offhand. But really the medications are usually a combination of 3 different drugs that we have available. So the oral medications are what we call 5-alpha phosphodiesterase inhibitors. Everybody knows about Viagra, the magic blue pill, the Cialis, or tadalafil that's available as well, the vartalafil. So these all help to relax the blood supply to the penis, because really actually when you don't have an erection, the blood vessels in your penis are actually constricted and preventing inflow into the penis. With an erection or with arousal, then the blood flow increases, and that's how these medications work. They help to promote that. We call it vasodilation, but really dilatation of the blood vessels and hence ability to have an erection. So that's the tablets, but they work systemically. So you take it, and then a few minutes or a few hours later, it will augment your erection. That's another concept that we need to know. It will not give you an erection. You must be able to have an erection. It will make your erection better. Whereas the intracavernosal therapy, that's a fancy term for just a small injection. I know men hate the idea of hearing an injection or needle near the penis, but we use a very tiny needle to inject in the drug directly into the penis, and therefore it's directly in the end organ, and it is really a very effective form of therapy, which, as I said, I'm trying to work with my pharmacy colleagues to offer men these options. But there's alprostadil, there's Trimix, there's Bimix, there are quite a few products on the market out there, but it's just been a little bit of issues with supply chains. And then also another product I'm trying to get here as well is the topical agent, where you place this on the head of the penis. And again, the drug goes directly into the penis, right into the target organ, and hopefully help you with your erections.
Dr. Rouse, you mentioned though an interesting point. You mentioned that women with diabetes are also affected in terms of sexual dysfunction. I don't know if there's anything, I know you're not a gynecologist, but if there's anything you can share. But it's also important to note that in relationships then there needs to be some understanding and looking out for the partner so that you can get whatever situation addressed.
Yes, it's sex and sexual activity. I always try to remind men that it's a two-way street. It's all about you and your partner. I find the men who are accompanied by their partners have better outcomes because then their partners can understand things a lot better.
Exactly.
It's also about getting that psychology right, having realistic expectations. A lot of men and a lot of the songs out there, a lot of the movies and everything always make it seem like you have sex for several minutes to several hours, which is really not true. That's really not how the physiology really works. And to bring in the point about women, they can affect women from their, similarly to men in terms of their orgasmic function, things like lubrication and stuff, because of the neuronal injury that it causes to vagina, the vulva perineum. And from that point of view, then women get dysfunction from that point of view. Sex becomes painful, it becomes uncomfortable, and therefore then they don't want to engage in that. And then again, the whole spiral occurs. My partner wants to have sex, but I have pain and discomfort. I don't want to have sex, and it just spirals and spirals. So you got to really try to break that psychological problems that arise as a result. So that's why it's so important to have the partners there as well. And also then they can understand from each other the problems that they're having, because a lot of the times the one partner might be suffering in silence, quite frankly, and that's not what you really want, because as I said, it's really a two-way street there.
Okay. Cassandra, I want to come back to Giles Ben, the amputee that we heard at the beginning, because he raised some interesting issues in that interview. One of the matters that he raised was a difficulty in finding the right medication. I was a little astounded when he said that for almost 5 years he was running to the bathroom regularly, which is seen as one of the signs of your sugar being out of control. He then said that he had stopped taking a particular type of medication because it was creating this situation of what he called uncontrolled diarrhea. And thirdly, he said he was hesitant to go to the hospital for treatment because of the reputation that the hospital had for cutting off your limb. Now, that brings us to the other specialists in this discussion tonight, and I'd like perhaps to go first to Dr. Selwyn Ferdinand to get your thoughts on that kind of experience which has been shared by us by Mr. Ben. Good evening.
Good evening, Mr. Ferdinand.
Good evening, and good evening to the listening audience. Yes, David, I think Mr. Ben was relating a reality that has been existing for several years. And I have to admit that at this point, I think the methods that have been employed by which we could change that perception have not worked. For lots of persons in Barbados, the place where you end up when you are ill is in the Queen Elizabeth Hospital. When the perception in the public becomes that don't go there because you are going to end up with an outcome that you don't wish, that serves as a poison, for want of a better term, which is extremely difficult to overcome. Now, I've spent several years in various fora trying to combat some of these perceptions. And I'm not so sure that I've been successful. I think a number of my colleagues have also tried from the Department of Surgery and surgeons in general. But it is one of those perceptions that persists. You know, it's very easy to propagate these kinds of perceptions. You know, even coming from some persons in the medical fraternity, they propagate these perceptions, and so it has lived on. When you have no other alternative for the patient, I think we have to be looking at different approaches. So I can't be specific in terms of what I think can be done because it is a national problem. But I can say that trust has been broken down, relationships in terms of understanding the perspective from the physician as to why decisions are made, how decisions are made, what alternatives may be available, all have to be explored so that patients come to understand the realities.
Let's come to the podiatrist, Tony Pickering. From what you heard from Giles Ben, what were your concerns coming out of what he said?
Well, good night. Good night to my colleagues and to public of Barbados that may be watching or listening. Well, some of my concerns really stemmed with again, as Dr. Ferdinand said, the the way how he felt about his medical care and what he thought about with respect to what was his next step. And as Dr. Ferdinand was speaking of, Barbadians do have a very poor perception of what the hospital can offer and what the hospital has to offer. And I hear this on a daily basis. And I will agree with him about some of our colleagues actually um, portraying this and expressing this themselves. But I also have to draw a reference to the fact that sometimes the experience at the actual QEH facility is not comforting, and it's not a situation where I think you need to comfort the patient. It is a situation where the person that comes in is quite scared, which I think that's how Mr. Ben felt. This is a position and a situation that he was never in before, quite concerned of what the possibilities would be with his limb. It may have been a situation where he didn't completely understand the consequences that can happen where he was at that point in time. But a lot of the steps that he took were, in my opinion, not wise, because there are usually certain protocols that you have to um, certain protocols that you have to explain to the patient and certain things that should be done. And drawing reference to Mr. Ben in his situation, what a lot of people don't realize or what a lot of people don't understand is that when you get a nail puncture or any foreign object that actually pierces and goes deep into the skin, you should go to QEH. That is your first point of contact. Not your medical doctor, not myself, not your nurse, not your friend, not your herbs in your cupboard, but the QEH hospital. And that's really because of, no, this is something that you need to draw on, because people do a lot of strange things. And
Yes.
I try to educate my patients that, you know, it is a scary experience, but there's nothing that I can do for you at that time, because this needs a surgical opinion. So, and this is just drawing reference on Mr. Ben. In other situations, you know, I always tell patients, you know, if you're concerned about something, if you're not comfortable with something, see your podiatrist, see your GP, speak to somebody who you are comfortable with in your medical field, but definitely something that is permanent, like a wound or abrasion, a cut, anything that actually pierces your skin and causes fluid and things that don't look normal. Consult your GP, speak to your podiatrist
But
about
with
it, and they
urgency.
should, with
Yes.
urgency,
Okay.
because, you know, sorry.
No, I was just going to say we have to pause here. We still have a lot to
That's
talk
fine.
about. You just heard from the podiatrist. Still to come, we're going to hear from Tracy Bushell, diabetes specialist nurse with the Maria Holder Diabetes Center for the Caribbean. But right now, we're going to take a pause from Your Health, Your Action for lotteries.
Any questions? Well, okay. So we can go to Tracy.
Okay. welcome back to Your Health, Your Action. And this evening we are focusing on diabetes and the complications of diabetes, with specific focus on impotence or erectile dysfunction and amputations. We started this evening by sharing a bit of the experience and life story of Giles Ben, who is an amputee. And of course, you've heard from several of the specialists already about some of the situations and circumstances presented and the complications that are direct effects of uncontrolled diabetes. So David, we really want to get to the crux of the matter. There are questions, and we still have another specialist to hear from.
Yes, we'll hear from Tracy Bushell, who is a diabetes specialist nurse with the Maria Holder Diabetes Center for the Caribbean, as it calls itself now. Nurse Bushell, what really strikes me in looking at this subject is the fact that you've got the polyclinics, you have the foundation or center that you are associated with, you have the Diabetes and Hypertension Association, but there is a bit of confusion in the minds of people who, especially those who are newly diagnosed. This system, they don't seem to know how to navigate it, where to go to get what. And while we are saying to people, you need to be controlled, you need to look after yourself and that sort of thing, and especially for the poor, because the poorer people in the community are the ones who bear the brunt of this kind of challenge. People who have money can go and pay privately, but when you don't have money, then it comes across as though you're butting about and it's difficult to know where to go. How do you advise people to navigate this system?
Okay, hi, good night everybody, and thank you for having me on the show, and good night to all the public out there as well. It is a minefield, I totally agree. As you quite rightly have pointed out, there's the various organizations. You have the Diabetes and Hypertension Association, you have us, and you have the Polyclinic. And for us at the Diabetes Center, we have the opportunity for public patients that belong to the Polyclinic. So for those that are newly diagnosed, they would hopefully go and visit their GP at their Polyclinic initially. But we are what we sort of suggest as a one-stop shop. So have a consultant diabetologist, myself as a diabetes specialist nurse, podiatrist, i.e. Tony, and we have wound care nurses as well, specialist dietitians. So to actually be able to glean the relevant information up front at the beginning, to be able to offer all the tools under one roof, all polyclinics can actually refer their clients to the Diabetes Center for a 6-month public program, which is free of charge and paid for by the government. So as a newly diagnosed patient, you would actually get all the relevant education, which is my key role, as well as the specialist input. And then they would then be referred back to their clinic or their polyclinic to enable them to go forward with the idea that, self-management skills would have been acquired. So that's where my role comes in, and our remit at the Diabetes Center. And of course, we have the wonderful Diabetes Association and Hypertension as well, which offer education programs. They run the Conversation Map, which is a 6-week program for persons with type 2 diabetes. So, with the joint efforts, and I think that's the key thing, it's actually coming together as a team and not segregate everybody with diabetes. As you can tell, I'm from the UK, and that's how we've always worked. So this centre was something quite new to the Caribbean, not just to Barbados, as a multidisciplinary team. So very new concept that wasn't known to most people and the public, were unsure what it was all about. But I think if we can come together, whether it be the polyclinics, even private clinics, and us as the Diabetes Centre and the Diabetes Association and Hypertension, sorry, I'm getting that bit back to front. We can actually guide the patients and our clients to receive the best care that they're entitled to in terms of the management of their diabetes and preventing complications.
Okay, let's pause here. Nurse Bushell, we're going to take a caller. Good evening. Welcome to Your Health, Your Action. Go ahead with your question.
Yes, good night. My name is Ernesto Boyce, and I have both legs amputated. And I think that some people say you get your legs cut off too fast at the hospital, but I can say no, because sometimes with the pain, there are so much pains that you were glad to get them off. I had poor circulation, and hello?
Yes,
We're
go
listening.
ahead. I think your television
Try
may
not
be
to
up.
listen to your TV, please. If you could turn the volume off your TV, that would... Yes.
You had poor circulation, you said.
I have poor circulation. I was in the hospital for years with it. But my job was a standing up job, and the doctor told me if I stand up bad on one side, then you try to shift on the other side. That way you get these things. Then
So you had diabetes?
Yes, I'm a diabetic for years. I went to attend Dr. Pickering too with my foot. And it come that one time, I had a small split between my toes. And I didn't attend the clinic. The doctor prescribed, she said I would address it, but next 6 weeks it break up again. And they wanted the split just open. And it was pains, unbearable pains. And I determined I have to get hospital. I just break down. I didn't want to go to my hospital. Doctor, Miss Ward, I have to get another second opinion. And when I get this second opinion, you have to lose your foot. That was one. That was in 2017. I lose one in 2017. It cut below the knee. I love that cut. Then it takes 6 months to wear. Then the doctor said, no, it only 6 weeks. I have to cut it again above the leg, had to cut above the knee, up in the leg. All right, and it's 4 weeks time that they wear. Now in 2021, I had a toe that this toe started to give me trouble. And I went to the hospital. This toe was not better. I have to lose the foot. It was this. I don't know. I can't describe it.
When did you lose the second leg?
In 2021.
And what has that been? That's not a long time ago. So how has that impacted on your life?
It was hard at first. I watched the doctor cut off that. I watched him cut off that. It had no blood. It was poor circulation. It had no blood in it. And he told me, I said, Lord, what am I going to do? But thank God I have good children. I have good neighbors. I can cook for myself. I can bake for myself. Once I lock my chair and I ask God to help me, He will. People say you cut off your foot too quick, but I cannot say that. Because when them pains hit you, they are unbearable. And I thank God I have a nice nurse there near Nurse Lane. I will take my hat after her anytime.
I want to thank you very much for sharing your experience with us. But this question is for the specialist. So you lose both legs, and therefore, what after that? You still have diabetes. There's still a management issue. What's the kind of advice that you give to patients in that kind of situation? Who's going to take
Is that a question for me? Sorry.
My apologies. Mr. Ferdinand, can you take it?
Yeah, well, so there is one of our favorite aphorisms: rehabilitation converts a patient back into a person. And so the issue of whatever the indications were for the amputation, after that process, the emphasis on care is to get that person rehabilitated to their best potential. And that's where our rehabilitation department comes in to take over that responsibility of care. So in addition to the managing of the diabetes, the specific processes of rehabilitation fall to that department to get the person back to their best potential.
And it brings us to explaining some basic concepts. People hear about type 1 and type 2 diabetes. Explain for the public, what's the difference?
The type 2 diabetes is typically what we describe as maturity onset or adult onset diabetes, where there is a resistance to the functioning of the insulin that your body is producing. The type 1 diabetes is much more likely to occur in children or very young adults, and it is where something has happened to the gland that produces insulin, that you do not produce enough insulin to control your blood sugar. And that's the fundamental difference between the two.
Because Sandra, one of
the ways you manage them are also different.
Well, you need to perhaps spell out how that is done. What's the difference?
Right. So that in the type 1 diabetes, almost always, because your body is not producing enough insulin, you have to get insulin supplementation for treatment, and typically that is given initially in the form of injections of insulin, but as technologies have advanced, we're now into the situations where you can have insulin pumps, etc. Mm-hmm. For the type 2 or adult onset diabetes, typically you use medications to assist the pancreas, the gland in your body that produces insulin, to produce or increase the amount of insulin produced to cope with the higher sugar levels. And there are a number of different types of medications that can be used to achieve that function.
And I just wanted to ask a little more about medications here, and I don't know if you're going to continue to speak on this, Mr. Ferdinand, or if Nurse Bushell will also add her perspective. But one of the other things Mr. Bend spoke about was the fact that he just stopped taking some medication that he was prescribed to help control his diabetes because of one of the side effects. We need to talk about the importance of having conversations with your healthcare professionals before just stopping medications.
I can comment on that. It is one of our cultures in Barbados, so that the doctor prescribes a medication. For a variety of reasons, you may be experiencing a side effect. Very often, all too often, I dare say, rather than have the conversation with the doctor, the patient makes a decision, sometimes on the advice of relatives or trusted friends and so on, that look, them pills ain't good, man, don't bother with that. And they may stop taking the medication and have not given the physician the opportunity to try to engage, to look at alternatives, and to look to see what other options are there. There are several options of medications for adult onset diabetics to try to manage their blood sugars.
I come back to the podiatrist, because there is a trend generally where many people see the podiatrist as an extra cost, and therefore they don't sometimes even see the podiatrist as being important. And I'd like you to outline to members of the public exactly why it is so important to see a podiatrist and how easy is it to do so.
And early.
Yes.
Well, it is important. The reality of it is that every diabetic should have a podiatrist and should have a relationship with a podiatrist. So every diabetic. And that doesn't matter if you're a type 1 diabetic, a type 2 diabetic, if you're a child, if you're a granny. And the reason why that is because we are supposed to be, and we are, specialists in the lower limb. And it is important because we tend to be the ones who are well trained with detecting things early. We do a lot of preventative care, a lot of things that people know us to do, cut nails, manage callus. But it's important that we actually have that relationship with the patient, because we get to educate the patient not only about self-management, as somebody had said earlier, but how how to detect things early, what kind of relationships they need to have with their other practitioners or whoever else is involved in their care, and just to help get them on the right path. Really and truly, podiatrists are far and few in between in Barbados, and I it is not something that is out of the way for people to study. There are ways and means that you can actually train for it. And right now, I would say that we have a crisis where we are short of podiatrists. And right now in Barbados, I can say right now there's 6 of us practicing, whether we are in the polyclinic system. Mainly, I think there are 2 of them now, and 4 of us work privately. And the problem is that we have to manage the same population that all of the other doctors manage. So it becomes difficult to actually manage a large population of diabetics. I remember maybe about 10 years ago, 1 in 5 people in Barbados were actually diabetic. So you can actually understand how much that is with a population of just over 200 or just about 270,000. And we still deal with people who don't have these issues. We deal with people, children, vast things that affect the feet. So it becomes difficult to see the patient. But I always tell my patients, and I always advise diabetics, that they should still get in there and speak when they call for appointments, or when they speak and explain what is going on. Because I always find time for them, and I always try to put them in, especially if there's a problem or if they sense that there's a complication. But
Quickly,
as I said, self-management is important.
Quickly tell us about self-management, because that's a very important part of it, especially in light of the fact that you say there are so few podiatrists in the country.
Well, but I can speak from my point of view and what I say. I usually tell patients, I give them education about what they can see, what they know would be normal. Color of the skin, texture of the skin, how it feels, how it looks. So I tell them, well, this is how it should be. If you find, or this is your normal, because everybody's normal may be different depending on where they are at that point in their life, or their diabetes life, so to speak. And I always explain to them, this is where it is. If you see any change in color, texture, foot gets hot, check between your toes, make sure you clean around the toe and nails, don't pick at anything, try not to cut things, try not to do self-management with respect to, if I have a cut, put in aloes on it, put in Vicks on it, all kind of strange things people do. But it's really just to get them aware of what is not normal, what is important. And I always tell them, if 2:30 in the morning, you get up and you go to the bathroom and you hit your toe, and you have no way of getting to the hospital, you cannot nobody can take you to your doctor's clothes. You should at least have some Behadine at home, or some iodine, some sort of bandage or gauze, so that you can do something to your foot at that time, so that when you get to where you're going, that you have some point of treatment, so to speak, and minimize it. Don't do too much fanciness, and let the professionals deal with it. So I always try to educate them, as I said, how everything looks, how it feels, and generally, so that they can have an idea of what is abnormal.
I think this is a question here for you, Ms. Pickering. Perhaps you can respond to that as you speak.
Okay, I'm having a funny feeling.
I'm having a funny feeling in my left leg, like something is crawling under the skin, and pain in the upper thigh and hip.
Right. So generally, feelings of things crawling on your legs, or those kind of strange sensations, things like numbness, tingling, burning, pins and needles, those things are really nerve related, and kind of a signal from the nerves that something is wrong. And if it is a situation where it's traveling up into your thigh and your hip, it might actually be related to your sciatic nerve, or the nerve in the lower part of your spine. With something like that, you have to consider when you're getting the discomfort, or when you're actually seeing these things occurring. If it is worsening at certain time frames, if there's any activity that worsens it, if there's anything that you do that helps it, if there's any change to your medication, if you've stopped taking your medication, different things like that, any accidents, back pain, injuries, whatnot. So there's a whole range of analysis that comes into play when you actually have something happening like that. But generally, that is something that is nerve related, and you should speak to your GP. It wouldn't necessarily be myself, but based on how it sounds, randomly, something that the general practitioner can manage, and they should refer you on to the necessary specialist.
All right. I think we also had a caller, so let's take that call now. Good evening. Welcome to Your Health, Your Action. Go ahead with your question. Good evening. Please remember to lower the volume on your television set and just go ahead and ask your question, please. Okay, so there were also a few other questions, I believe, being sent via WhatsApp. We are open to those questions at this time as well. You can call us though at 228-5562 or 228-5563 if you have questions related to the topic this evening, diabetes and complications of the disease. We've been focusing especially on impotence and amputations. So here's a question. He said he stopped taking the meds because of the side effects of diarrhea. My question is, why wasn't he prescribed another medication? Well, I think we might only be able to assume at this time because that was what he said. So
a lot of that depends upon the consultation
yes.
that he's had. I was
And
particularly worried,
that.
as I said, that it took him 5 years to be going to the bathroom with frequent urination, and that he had a problem trying to identify, he says, exactly what was the medication, the mix of medication that would work for him. Now, how many other people who are diagnosed as diabetics may well be facing that kind of challenge, even though they are discussing it with a medical professional. And I suppose we haven't had a comment from Dr. Rouse for a while, but between you and Nurse Bushell could perhaps take that quickly.
Well, I would say it from my point of view in terms of, as Mr. Ben outlined, where he had significant lower urinary tract symptoms in that he was going frequently, going urgently, he was probably getting up several times at night. And I think also Dr. Ferdinand touched on this point earlier. One of our cultural norms is, and I'm sure it happened
yes.
to Mr. Ben there, when he was prescribed a medication, he got a side effect from that medication. He lost confidence in the system. And I think patients need to understand that nothing, so one medication that might work for you might not necessarily work for another patient. And because you have a side effect doesn't mean that your doctor doesn't know what they're talking about. You should really go back and have that conversation.
Absolutely.
And I think patients need to understand that a lot, because it happens in all aspects of medicine here in Barbados in my return to the island 3 or 4 years ago, in that when there's a problem, patients automatically assume that the doctor doesn't know what they're doing, or they lose confidence in whichever health practitioner they're seeing, and abscond from care. I think that concept, they need to understand, yes, that sometimes the medications might not work right away, and we might have to try 2, 3, sometimes even 4 different drugs before we get it right, but we will work with them to get them to that point in time and have some faith in the system, that we're there to look after them. I think that's one of the fundamental underlying problems in medicine here in Barbados.
Dr. Rouse, coming back to the issue of impotence, we have seen several reports and many anecdotal stories that more and more young men in Barbados are going towards sexual enhancements. They're doing that against a backdrop of a country that has a high degree of predisposition to diabetes. Tell us what you see as the potential dangers down the road for young men. And when I talk about young men, I'm talking about men under 30 who are very much involved in this process. What do you see as the potential dangers there?
The potential dangers there, the first problem here is, again, the psychology. I think our Western society is very heavily, sex is right up there in the forefront. And we have this really horrible misconception that men need to perform for hours, quite frankly. If not, they're not a man. And that's the first concept I have to, a lot of the times when I see young men in the clinic, dispel, get them having the right perception, the right frame, getting them to understand it's about not only them and their performance, but also their partner. And then counsel them about taking these drugs, these over-the-counter medications. Yes, there are natural products, natural aphrodisiacs. For example, for LUTs, I welcome men using saw palmetto. They've been tried and tested and proven. But a lot of some of these products that you buy, especially over the internet, that promote that they can do all these amazing things, we just do not know how they're made, how they're manufactured. Because as a food supplement, that's how they usually coming under the guise of. There's no regulation of that market. You're not really sure what you're getting, and there's a real danger out there of getting not so good products. And ever so often you get recalls like this, and you see various products being pulled off the shelf because of this. One of the other problems with them is that they contain, as I said, a lot of these contain supplements, contain the phosphodiesterase inhibitors, the sildenafil, the tadalafil, in quantities that we're not sure of. And I do think that with long-term continued stimulation, unnecessary stimulation of these normal physiological pathways, your body becomes, and this is my personal opinion, this is not medical, medical, is that your body then becomes dependent on this. You become psychologically dependent on this, that if you don't take product A, you're not going to perform. And then you don't take it, you don't perform, and it builds up the psyche, and it's just like any other drug out there.
Well, we're going to have to more and more. We're going to have to wrap you up now. Yeah. We're going to have to wrap you up.
So I think there's a danger of becoming.
There's quite a lot more to be said. Yes.
Yes.
Thank you, Cassandra.
Yes, I really want to thank, though, Giles Ben for sharing his experience and all that caused him to be where he is with us. And hopefully you are learning from that experience and the questions that came up here. So a question about diet, we'll deal with that next week in part 2 of the Focus on Diabetes. We'll have the psychologist and we'll have the dietitian back with us. But we thank you for your calls and for your questions.
We also need to look at diabetes and the eyes next week.
Yes, yes. It's all going to be here. So we want you to tune in. Thank you so much to all our partners, the NGOs and media partners for making sure that you can be a part of it and you hear it. So remember, this is all about your health and your action. The time is now to take action. It's been a pleasure. Do have a good night.
Good night.